So today we're going to go over image guidance and guidelines for matching and alignment methods and workflows. So kind of a clinical, practical overview of using image guidance for radiation therapy. So just to start out, let's think about why image guidance is important. So let's say we're trying to paint into this target here. If we have kind of an analogy to what a 2D, 3D conventional radiotherapy without image guidance would be, it would be like we're trying to paint this, but we have a fairly large brush, not the most, I mean, it's a good tool, but it's maybe not the most delicate or most finely accurate tool for painting the target. So we can paint this target here. We also don't have a very good view of exactly what we're painting, but because our tool is pretty big, it's going to be pretty easy to hit that target. If we then move forward to more of IMRT techniques, this is like a much finer tool. We can really paint the dose very carefully to what we want. And so we get these very conformal dose distributions when we're painting it in. But without image guidance, we still have some difficulty in knowing exactly where we are painting when we paint that dose in. And then if we add in image guidance, now all of a sudden it's like we're taking the blindfold off. Now we have a fine tool that's ready to use, and we can see where we're painting. So we kind of we can really best utilize that tool of dose painting with IMRT because we know exactly where we are aiming that. So for instance, if we take the target again, if we have different fractions from a conventional 2D, 3D radiotherapy, those may vary in location, but because it's not going to be the most conformal of treatments, a lot of those details about exactly where it's lining up aren't as important because there's going to be areas outside of the volume that's going to account for that uncertainty. And we still have to worry about margins, but usually we're okay because the uncertainty from image guidance is not as big as our uncertainty in our ability to conform to the target. So kind of to summarize that situation, in this case, the radiation volume is larger than the target and there's less risk of missing the target. If we have IMRT without image guidance, we may be able to paint a very tight dose distribution. However, if we're careful and we don't think too hard about the margins, if we may line up right on or we may line up off. So as you can see in this case, these margins are too small if this is our uncertainty from day to day. And so you have to be very careful and instead maybe paint a larger dose distribution. Then maybe we're able to paint a smaller one, but we have to build in some uncertainty based on the uncertainty of the setup, depending on our immobilization technique and all of those details and location in the body. So without image guidance, we're going to be limited in how small we can paint this volume because of the uncertainty in our setup. So in this case, to summarize, we have a better ability to conform to the target, but the risk of target miss there is a risk of target miss if the setup uncertainties aren't accounted for. So some of that benefit of the ability to conform, we can't really realize without image guidance because of the increased uncertainty. Now, if we include image guidance in our treatment, each time we set up, we will be able to minimize our setup uncertainty. Now, we still have to account for it. We still have to have a good idea about what that uncertainty is based on the patient, based on the immobilization, based on all the technologies that we're using and the image guidance that we're using. And we need to have a fair idea about what type of uncertainties we have and make sure we're managing it well. But ideally, when we do that, we can shrink the margins down and really fully utilize the ability to conform that IMRT provides. So to summarize, we have an ability to better conform to the target, and image guidance minimizes the setup uncertainty and enables better conformity. So this is kind of just a summary of why image guidance is important and how it fits into some of the other technologies like IMRT that have been developed and implemented in the clinic. So there's lots of different ways that we can achieve image guidance and different technologies that are available. This includes megavoltage imaging systems. So on the right here, you can see two different LINAC systems. And on the top one here, we have our gantry head, and where our megavoltage therapy beam is generated. And we have a flat MV flat panel that's mounted, and orthogonal to that, we have a KV source and a KV flat panel, and similar with the LINAC down below here. And so for the MV imaging system, we can do 2D imaging. This could be portal images and also cine imaging. And then in some cases, and in the literature, there's been techniques to use MV cone beam CT. So this is where you take kind of portal imaging with different projection images, and you use that to create a cone beam CT. Now that's not very common. One of the problems is that the dose for that can get quite high if you're not careful. So it's not a very common technology. Probably the biggest exception to that is tomotherapy, which does MV-CT. And then for KV imaging, we can do 2D imaging like radiographs and fluoroscopy. And then we can do 3D imaging like a KV cone beam CT. And these are quite common. And I would say that the 2D imaging is also quite common, obviously, for MV, the MV 2D imaging. There's also other image guidance modalities that are out there that are not mounted on the gantry per se. And so here's a couple of these other modalities. One of them is like stereoscopic imaging, like KV imaging. So you have orthogonal imaging from these mounted X-ray sources. So you have these X-ray sources that are mounted under the floor and in fixed position, and then you have panels up above. And so this image is right at the isocenter, and you always get images that are orthogonal to each other. On the right, this is, in some ways, it's not exactly image guidance because you don't really get an image from it, but it is a method of patient localization, which is use of electromagnetic transponders. So here we have like usually three transponders that are implanted. Typically, this is for prostate. And this was very popular for a while, but it's still quite a specialized technique. And basically, these transponders are implanted. There's a electromagnetic array that is used to read the transponder position, and then there's infrared cameras in the room to know where that array is. And so this and some other things kind of like it are, I would say, kind of uncommon, but it's good to know that these things are out there. And then finally, on the bottom right, there was a bit of work looking at using ultrasound as well, and so this is also a possibility. So you can have some type of ultrasound probe that is used for image guidance in the clinic. Again, all of these are just kind of out there, and there's other ones as well that are less common, but they are possibilities. And I would say on the two options on the right here, one benefit would be the lack of ionizing radiation that is needed for the localization technique. All right, so the image guidance process typically takes some type of form like this. The patient is set up for treatment at the linear accelerator. An image is acquired at the linear accelerator. There's a reference image that's derived from the patient geometry at simulation. And then those two images are fused, and the translation of the images relative to each other is calculated. And then that information is then used to adjust the patient setup. And then this really should have kind of a feedback loop, because in some cases that then may be used for follow-up measurements if the adjustment is large, so that there's a possibility of then repeating this process. And sometimes these are called the source or moving image and the target or fixed image. So when you have image fusion, you may hear those terms of target and source images, and just to know that those are really referring to one that's acquired at the linear accelerator in the patient geometry that for that day of treatment, and the other one referring to the geometry at simulation, which, as you can see here, this is a radiograph that is derived from the CT taken at simulation. Another thing to keep in mind is that there's different roles for different professionals within the department. And so here again, we have this kind of a workflow for image guidance. So the patient is set up at the treatment linear accelerator, image guidance is acquired at the linear accelerator. We have the reference image that's derived from the patient geometry at simulation. There's an image fusion. The fusion is reviewed and approved. The patient setup is adjusted, and then we treat the patient, and potentially there could be some infrafractional imaging depending on the need and the desire, protocol, so on and so forth. So, and the one thing to note is this approval, the review and approval, in some cases occurs before the treatment, and sometimes it occurs after the treatment, and that may just depend on the type of case and the protocol and how things are done in each specific clinic. And so where each professional or specialist falls in here, I've kind of marked out. So the therapists do a lot of the setting up. The image fusion may be done by the therapist or the physicist. The physicist and the radiation oncologist may be involved for the review and approval of the images. The therapist would adjust the setup typically, and then treating the patient is done by the therapist. It's possible the physicist and maybe radiation oncologist may be present for the SRS or SBRT cases, for instance. Other roles that aren't really in this workflow include the radiation oncologist prescribes the type and frequency of image guidance, defines the CTV to PTV margins, accounting for the localization uncertainty, and the dosimetrist physicist prepares the plan with any images that have to be prepared for image guidance, adds the image guidance details in the setup note, consults with the radiation oncologist on appropriate image guidance and CTV to PTV margin. So this is kind of behind the scenes. It's not really in our workflow here, but it's an important step in the image guidance process. Some of this may happen on a per patient basis, and some of this may happen for these specific cases, we're going to image this way, and we just always do it a certain way. And so we always have these specific settings of image guidance for these specific cases. And I think that can be a really good idea, for instance, to know for these specific types of cases, we're always going to do this type of image guidance in this frequency. And because of that, we know that our margins should be around this, or so on and so forth. Those are good things to think about ahead of time as a clinic and come up with a protocol. For the image registration, we have the target image and we have the source or the moving image. So for 2D image matching, the target image is a digitally reconstructed radiograph. That's a DRR for short, from the simulation CT. So what this does is you take the 3D CT and you make a projection through it of what the attenuation will look at a certain angle. And so then when you go to match at the patient, the source image will be basically the radiograph, either an MV or a KB radiograph that will match to that DRR. For 3D image matching, the target image will be the simulation CT itself, whereas at the source or moving image will be the KB CBCT that's acquired, or MV CBCT or MVCT. For 2D, 3D image matching, which gets a little confusing, you can have orthogonal KB MV radiographs for your target image, and your source image would be a series of DRRs that are created from your simulation CT. So in other words, you take your images that you acquire at the machine, and then the algorithm will iteratively create radiographs to match, to find what your best match should be between the two systems. So on the left, this is from an old paper showing what the concept of image guidance. You have this radiograph. Basically, you have your CT. You render this 2D image from your 3D image, And then in the physical space here at the machine, you have an X-ray source, a film, or a portal imager, and you create this image of the patient, and then you can then register those. And on the top right here, you can see an example of a digitally reconstructed radiograph, and on the bottom, you can see an example of the projection image. This is a KV projection image that would be matched to it. So for the patient positioning and treatment, so a typical process would be to align the patient marks to lasers to get really close, verify and fine-tune correct patient position by matching live daily radiograph to the DRR. So basically you start as well as you can, and then you take the image, and then you would match. So here's another example of a 2D match where you have your radiograph created from the simulation CT on the left, and your projection image acquired at the machine on the right. And here's an example of the orthogonal images. So if you're doing, for instance, 2D projection imaging, it's a good idea to take orthogonal images, and lots of systems will allow you to match those simultaneously. So you come up with a single three-dimensional translation in 3 dimensions of those 2 images to match. And so your superior inferior direction is kind of shared between your 2 images, and you get your anterior posterior shift from your lateral image, and you get your right to left shift from your anterior posterior image. And you can see here that this is kind of cut, so you can see both the projection image and the DRR. Left here is the lateral view, on the right is the AP view. Here's an example for 3D matching. So on the left, your target image is the simulation CT. This is the CT that's used for treatment planning. And on the right, we have a source image that is this is the KV CBCT that's acquired for the day of treatment. And then those can be fused together, and you get basically the best. Either it's a translation, typically translation in 3 dimensions, but could also include a couch rotation. Although you have to be careful about that and not have such a large couch rotation that you're going to cause any potential collisions. That's something to keep in mind. So again, this is just an example of the diagnostic X-ray CT at simulation on the left, and then at treatment on the right. So you can see here, you have a different setup for how those are taking. The simulation CT is typically going to be fan beam, conventional CT. On the right, it's a cone beam image. And so it's taken, and you use a flat panel to acquire that image. And so there's going to be higher scatter, lower quality image that's being matched, but it's good enough for a lot of, you're not really using that for dose calculation. You're not really using that for defining the tumor. You're just using it to localize the patient. So a cone beam image can be good enough quality for that type of use. And here again is some examples of the orthogonal KV radiographs and the DRRs as well. And you can see here, this is taken from a paper where you can see the type of the process that happens for a 2D 3D matching. So 2D 3D matching is a little bit different from what we would think of as a 2D match. Going back, a 2D match, you have projection image, a single projection image that's created, a DRR from your simulation CT at 2 orthogonal angles, and then you just basically use those. For this 2D 3D match, you're using your target image. What's fixed is your images taken at the time of treatment, and then you create new projection images from your CT iteratively with different translations until you get a really good match. And so this is, and I wouldn't worry too much about the details, just to know that this is something that's out there and what's going on with it. Basically, it kind of flips the picture here so that you can create lots of different potential DRRs and find the best DRR that matches to give you the right translation of your patient. So just a comparison of the 2D 2D match with the 3D 3D match, these are the most common types of match that happen. So on the right, or sorry, on the top, you have a 2D 2D match. These are projection images. So within this image, we have the entire information going through the patient at this direction. So the attenuation through the entire patient is shown here. So you can see kind of all the teeth and everything like that. On the bottom, this is what a 2D 2D match looks like. And you can scroll through and see each individual slice of the patient. In fact, you can see there's 3 different windows here, and each one shows a different plane through the patient. And so you can match the patient in all 3 of these planes simultaneously and scroll through and see any plane through the CT and how your planning CT and your cone beam CT align. And you can see here, this quadrant and this quadrant are from our planning CT, and this top right and bottom left quadrant are from our cone beam CT, which has pretty good quality, as you can see here, for this head case. And we're looking at a single slice through that CT, so you could even see a little bit of the soft tissue in the brain here that could potentially be used to match as well. And same here, you can see this is a different plane and a different plane. So you can get a full 3D match with this kind of CT to CT registration. And up above, you're matching based on 2 projection images and the digitally reconstructed radiograph for this patient.
Okay, let me just verify this slide because it's very important for everybody to understand it well. Well, in the first upper images, we are matching 2D orthogonal radiograph. Those are DRR with the 2 orthogonal portal images, either KV or MV. Am I right?
Yes.
Okay. I want to send this message in Arabic, if you don't mind.
Absolutely.
شباب الصورة اللي فوق صورة ال DRR Digital Reconstructed Imaging من السيميوليشن، وبنعمل لها ماتشنج أو فيوجن مع واللاترال اللي بناخدها بالبورتال ايمج. اوكي، دي مش 3D، مش صورة 3D، دي صورة 2D، وبنعمل لها فيوجن أو فيريفيكيشن بالدي ار ار اللي احنا واخدينه من السيميوليشن. اوكي. The lower image are the 3D to 3D match. Those are CT planning with the CBCT data. In this match, I can go through I can scroll each cut from the CT, either the cone beam or the CT planning that I take it from the simulator. Okay? Is it right, Justus?
Yes, very good. Thank you.
So I will say it in Arabic again. CT planning اللي أنا أخدته من السيميليشن، في الحالة دي أنا أقدر أعمل السي تي cuts دي كلها بال 3D dimension verification. لو أنا عملت cone beam CT، أنا كده عندي صورة CT بعمل لها verification مع صورة CT اللي أنا واخداها بالcone beam، وبعمل لهم fusion مع بعض، وبقدر scroll كل cut وأعمل verification للتو images مع بعض 2D dimensions. فعشان كده عملت لها verification على DRR. الصورة اللي تحت صورة CBCT cone beam CT، عملت له fusion على ال CT planning imaging اللي أنا عاملاها في السيميليتر. Okay, thank you so much, Jess.
Thank you. Okay, yes, so just to point those out there, yes. All right, matching strategies. So you can see here on the left is a projection image, and that's being matched between, it's a KV projection images, APPA, and a APPA digitally reconstructed radiograph from the patient CT. On the right is a match between the planning CT, simulation CT, and the cone beam CT for that day. You can see there's a couple different ways that we could match this, because the information may or may not give us the exact same match. The first one is we could use bony anatomy. So if we use the bony anatomy, we would align the bony anatomy, and it could be done in either of these situations. You could align to bony anatomy. A second method is to use the soft tissue, and this is typically much easier to do with a cone beam in 3D space than it is to do with a projection image. Often the projection images do not include much information about the soft tissue, with a couple of exceptions, but this is a very good way to match when it's possible. But sometimes you may not be able to see that on the cone beam image or on the 2D image. So when it's an option, it's very good. The other option is fiducial markers when they are implanted. So here you can see these fiducial markers that have been matched for this patient here, and you can also see them. You can see them on the projection image, and you can see them on the 3D image. So those are three potential ways that you could align this patient. Some things to keep in mind is that bony anatomy, when we match with bony anatomy, one advantage is that it's high contrast. It can be used for matching with most or all imaging modalities. One disadvantage is that soft tissue and bone anatomy motion do not correlate perfectly, leading to CTV localization uncertainty. So you may have a little extra uncertainty, and it's good to, people have measured this. There's numbers in the literature. It's a good idea to keep in mind how much uncertainty you have between your bony anatomy and whatever your target. And that may vary depending on the location and also on the patient. The second method, soft tissue, one great advantage is that you can match the GTV, CTV, PTV directly. One disadvantage is that the contrast may be too low for accurate matching with some patient geometries and imaging modalities. So for instance, if you're just using soft tissue, but you can't see the soft tissue, you're going to add some uncertainty there just in the fact that you can't really, if the contrast is not high enough to see it on your image, or just maybe impossible to do for some situations. The third is fiducial markers. So the advantage here is it's highly accurate when they're placed in the PTV, and they're also high contrast. So in some ways, this is the best of both worlds. It can be visible in many imaging modalities. A disadvantage is that this requires that fiducial markers be implanted prior to CT simulation. So obviously, this may not be something to do with every patient, and it may not be an option. It just depends on your situation. But if it is an option, it can be a good tool to talk about with the physician, between the physician and the department and the physicists, and deciding if and when that would be appropriate, and that the benefit in the decrease in uncertainty for the treatment would be enough to justify implanting fiducial markers prior to treatment. So matching strategies, a couple of things for best practices. During planning, the CTV to PTV margins should account for the anticipated target localization uncertainty. So this means that the uncertainty is probably going to be larger for 2D to 2D or bony anatomy matching, or for infrequent matching. And it may be smaller for cone beam CT, for soft tissue, fiducial-based, and daily matching. And some of this may be a conversation about, how close are certain organs at risk, and how small do the margins need to be? And in order to get, that small of margins, what type of imaging is appropriate? So this is something that should be accounted for early in the process when you are creating those CTV to PTV margins. Or, for individualized cases, there may be specific individual cases where specific custom procedures may need to go into place, but it's a good practice to have outlined for specific types of cases, whatever that treatment site is, we will do this technique, which we know our margins should be this much for this technique. And by keeping all of that consistent, you can kind of do all of this work up front in figuring all the homework up front as to figuring out what your uncertainties are for each situation. And then it's possible often to have kind of a set CTV to PTV margin that we always use when we use this image guidance protocol. Second best practice to mention here is when matching, define a region of interest that incorporates the PTV. So there may be some areas of the image that if you align to, another part of the image may be off. And that can be quite common based on maybe a little rotation of the patient or deformation or just set up slightly differently. Because of that, you have to select carefully what area you're going to match the image based on, and then use that region of interest that incorporates the PTV so that the image is aligned at the PTV. Next, the match can be 3D, 4D, or 6D. So 3D match, it's like a translation in 3 dimensions. 4D, when I say 4D, the fourth dimension is a rotation that includes couch rotation. So basically, you're matching the translation and allowing a couch rotation. Or it could be a 6D if you have a specialized couch that allows to rotate the patient in 6 dimensions. You can rotate the patient in all 3 dimensions. And just a word of caution there is that the 4D and the 6D options can be useful, but you have to be very careful about potential collisions because you may be just fine with no rotations applied. But once you apply some rotations, there could be a potential couch collision. So that's just a word of caution. When scheduling patients, be sure to account for the extra time needed for image guidance. And because image guidance takes a lot longer than you would think it would, when you're taking the time to set up patients correctly, that can be an iterative process. And so often, the amount of time that the patient's actually on the table and being treated is quite a small fraction compared to the entire time that includes the setup and the imaging, which can take the majority of the time for the treatment fraction. A couple more cautions for spine treatments. Being careful to avoid matching the incorrect vertebral bodies. I mentioned this just because this can be a common occurrence because you can have something that looks really, really good if you're not looking at the ribs or the pelvis in the field and you're just looking at vertebral bodies, but you could be matched on an entirely wrong vertebral body. So just a word of caution there to look at the broader anatomy as well to make sure that what you're looking at makes sense. For matched fields, where let's say you have like a superior and an inferior treatment and they're going to be matched, you should take special care to avoid overlap. And this is something to think about in these types of situations. If you've got a fixed isocenter, or if you have 2 different isocenters, are you going to set up based on one of them and then just do a fixed shift? Does it make sense to, the thing to be careful about is if you image one and you shift and align that one, and then you treat the first one, and then you go to the second one, if you shift the patient based on imaging on the second matched field, well, now you have the potential for some overlap or a gap between those fields because they're matched. So it's something to just be cautious about. So here's just a table showing for different methods of patient setup for treatment and kind of the typical accuracy for those. So for instance, we can align the patient based on skin marks, based on bony anatomy, fiducial markers, and soft tissue, and what that requires, so lasers, MV or KB radiographs, and then cone beam CT. And the accuracy, as you can see, kind of gets closer and closer. Or the accuracy of the bony anatomy and the accuracy of the tumor alignment. So you can see here that it gets better and better as you think. Now this is kind of just a standard table, but there's lots of data in the literature as to exact numbers for specific situations. So this is just kind of a rough guidance, but you should look at each individual situation and what's in the literature as far as those accuracies go. I have a couple of examples here we can go over. I don't know if there's, up until this point, is there any further questions that we could address?
Well, we had one question from our friend Bastun. He asked the CBCT how much it takes time wise, and he asked about how many slices it will take. I already answered him, but you can always say more, Justice, because I cleared up that the CBCT is a volumetric CT. It's not cut by cut, and it takes around 5 minutes reconstruction and accustration. So do you want to?
That's right. So your gantry typically takes a minute or two for a rotation, and so you may have 2 minutes just for the rotation where the data is required, but then you also have to reconstruct that, and that'll take a couple minutes. And depending on the system, some systems allow you to select a smaller field of view, like superior to inferior, and then the cone beam can also be, it can be like a full field of view, or it could be a smaller field of view, and it could be a full rotation or a half rotation. There's lots of different options out there, and often you can control how high of the resolution it is, but your number of slices, as you mentioned, and it's since it's a volumetric scan, your acquisition time doesn't change because it's just one large rotation. It's just how it's reconstructed will determine your resolution in your superior inferior axis.
Well, I forget how many degrees is the rotation is. I forget it now. I don't know why.
So so if you do like a pelvis or a lung case where you have kind of a full body, often what happens is the imager is shifted to the side so that it doesn't acquire the full scan, or sorry, the full projection. It acquires, let's see if I can get it. 1 second. Let me just annotate here for a second. Oh, never mind. So it just acquires, a partial projection image that's like one side plus a little bit to the other side, and so you have to take a full 360 degrees for that scan. So you'll have a full rotation of going from, negative, or from 180 to 180 basically for your gantry. If it's a smaller field, like a head, in those cases, you don't need to offset your detector, and so you get a full projection of data for each angle. And so often you can get away with just a little over 180 degrees. Usually it's like 200 degrees or something for the scan. So you can do it either way, and it depends on how big the anatomy is. All right, so just a couple of examples of some cases and the image guidance that was done for them. So I just grabbed a few examples from our clinic. This is an example of a right axilla case, Merkel cell carcinoma of the right upper limb, including the shoulder, 60 gray, 2 gray per fraction. It's a 2-field plan, RPO, LAO, 6x photons, non-uniform CTV to PTV margin. The wing board, the immobilization is a wing board plus a backlock bag, head to the left. Most of the week there was no imaging, but just kind of weekly verification that it was being set up correctly. Here's a third example. This is a mediastinum VMAT case. So it's an arc that goes around, similar to IMRT. 50 gray, 2 gray per fraction, wing board, sponge under each arm, knee sponge, and it says orthogonal KB radiographs daily. So that's basically orthogonal imaging on a daily basis. Another example here, this is a 3D rectum. So 40 gray, 2 gray per fraction, 3 fields, 15x photons, wing board, sponge under each arm, knee sponge, cone beam CT day 1, and then weekly. Basically verify the setup a little bit more thorough on the first day, and then set up the same each day, but then weekly kind of verify. Another case, this is a lung SBRT. So 54 gray, 18 gray per fraction, so not very many fractions. Two VMAT arcs using 6x photons, treated with free breathing in a body fix, arms up. So this is similar to a alpha cradle, reusable one. And then the imaging was orthogonal KV plus cone beam CT prior to treatment at each fraction. So when you have these fewer fractions, higher dose, kind of a daily verification with cone beam.
So why here we hybrid the orthogonal KB with the CBCT in this case?
And I should actually add a little bit here. Typically, the orthogonal KV would be to make sure that we're set up pretty close so that when we take the cone beam, there's not much of a shift that happens afterwards. It's more of a verification. And that's just kind of a institutional preference. I think that you could do this a lot of different ways as well. And then often some of these cases, if it's known to have motion, we would actually probably follow that up with a fluoro imaging right before treatment with just one field that we thought we could see maybe the tumor motion, the soft tissue, and verify that that motion was within our field. So just another note is about the use of display filters. So often the software allows different ways of processing your image and visualizing your image. So this is the same image with this is a KV lateral radiograph, but with different display filters that are provided by the vendor. So you can see there's a wide variety here. And so it's good to know that these are out there and available. So for instance, you may have a default one, and if it's not working too well, it's good to know that you can go out there and try a different one and see if perhaps something else might suit your needs a little bit better. And that can depend on the specific case. As you can see here, some of these could help view maybe the soft tissue a little bit better. Others, it's really good to view the bone and so on and so forth. So just a good thing to know that's out there and available to help visualize and make sure that that image registration is going to be reliable and accurate. And the same thing with the 3D images. So this is a CT image, and you can see there's three different windowings here. One is the soft tissue windowing. You can see the soft tissue within the brain very well here for a CT. Another would be the bone, but as you can notice on this left one, the bone is kind of saturated out. So it's actually hard to tell where the bone really starts and ends. But we could do a bone windowing here where you can see even inside the bone what the intensities are. But now if you take a look at the soft tissue, it's very difficult to make anything out, but this is the same image, it's just a different windowing. And then on the far right, this is the full range. So now it includes everything, including, you can see a little bit better the immobilization device, but it's very difficult to make out the small details in the soft tissue window for that windowing. So again, it's important to choose the correct windowing and to use it appropriately. Another good example, I don't have a slide here for it, but another good example would be in the in the lung. That often the default windowing will be very good for soft tissue that's around kind of water density, but not good for lung, where you have the lower densities. So when you're matching in the lung, it's good to keep both your planning CT and your cone beam CT in windowing that allows you to see whatever density you're matching. And if it's lung, it may be a lot lower than what your standard windowing would be. And just another note about the time required. So we got a question here. What's the name of the filters? There are names for these. I don't remember exactly what they are. Yeah, I would say, and it may differ between vendors. So I think you can it's something like I would just look in the system and play around with and see what exactly you have as options. So yeah, just another note about the time required for image guidance, to be sure that you schedule appropriate time. Otherwise, it could be very frustrating if you don't want to assume that when you're not doing image guidance and then you add image guidance that you can treat the patient in the same amount of time. The beam on time is only really a small fraction of the time required for a treatment. Be sure to schedule extra time on the machine for image guidance. Accurate alignment can take time and multiple iterations of image guidance, especially at the first fraction. So often we'll have patients that have a first fraction that's scheduled for double the amount of time that they would typically be scheduled, or maybe even more. And you need time to coordinate availability of physicists and physicians as needed. It may be that the therapists do certain steps and then the physician has to come there, and that can take time as well. So just these are all things to be aware of in your schedule. And it's another reason for when you're deciding how to do your image guidance, how to best manage your time on the machine, the benefits to the patient. These are all things to be considered. So imaging dose, it's important to know that image guidance can add significant dose. This is a paper that I found that basically summarized dose for different image guidance procedures for the entire cumulative treatment. So for instance, there's a prostate and a head and neck case where they have different, they say, okay, here, if we have a prostate case or a head and neck case and we're using MV planar imaging or cone beam imaging or KB imaging or adaptive radiotherapy, what's the imaging dose going to be? So you can see here the protocols that they're looking at here is for the MV based, it's 10 imaging, so five times the first week, then weekly, or for prostate, it'd be 12 sessions, so 5 times the first week, then weekly. Cone beam would be 31 cone beam CTs daily at imaging, 39 cone beam CTs daily at imaging. So you can see here the dose can add up to about 1.4 gray. And this dose is not dose that's special, that's focused on I mean, here this is the dose at isocenter, but this entire imaging dose is not necessarily just delivered to the isocenter. It's kind of a full body dose. So it's something to keep in mind that image guidance has huge advantages in being able to localize the patient, but it also adds some dose. So it's just something to note and keep in mind when looking at the benefits and disadvantages for different image guidance in different scenarios. And the other thing to note is I grabbed the isocenter dose, but the dose varies greatly by location, and this publication has a lot of details there. If you're more interested in, if you want to know more about what those doses look like for different areas of the body. All right, the other thing that I added some slides here because I realized I hadn't talked about surface imaging guided radiotherapy. And surface imaging is newer and it has some big advantages. The main one being this is something that does not have any imaging dose. And so once you have the technology, it's kind of free information for image guidance. So basically what happens is you have some sort of an array, an optical camera, an array, and it measures the position skin surface. And here's an example here. You can see an example here where basically you've got some cameras and you're basically reconstructing this surface. So obviously, we've already talked about how bony anatomy doesn't perfectly align with your internal target position per se. And you'll have the same issues here with surface imaging. But that being said, it's, within something rigid like a head, there may not be that much motion or that much change, right? And whereas if you have something lower down in the abdomen, that correlation may or may not be larger. So this is a great tool to also keep in mind if it's an availability, and especially the benefit of no imaging dose. So it's something that can be used not just at first fraction, but can be used for every fraction, can be used throughout the fraction to make sure the patient has it. So it's a great tool when it's used appropriately. Some notes about using it appropriately is make sure that you use it with appropriate margins, just accounting for what that uncertainty is, and to really have a good, realistic idea about what the uncertainties are going to be using this. And the other thing is potentially combining this with other image guidance tools. It'd be a great thing to use, and often this is the way it is used, where, for instance, you grab a baseline at the first fraction, and at the same time, there's some other image guidance, whether that's 2D or 3D, cone beam CT, and then that you're set up well, and then you use that baseline for future treatments to use this surface imaging that doesn't have any associated dose for aligning the patient. All right, that's all I have. Thank you very much, and I'm happy to answer any other questions.
Thank you, Justus, for this nice lecture, really. We have many questions. I will go through them. From Shayma, there is a question that in case of craniospinal irradiation, when we take 2D match for the two spinal fields? How can we avoid overlap?
That's a great question, and really, craniospinal is a very specialized case, right? Because we are treating the spine, and we know that the spine. We really don't want to cause any overlap, because the spine can have terrible complications if you overtreat it. So what we do specifically at our clinic is, for each treatment, we align the patient and we image. So we'll either treat them with 2 fields or 3 fields, depending on how long the patient is. And we will actually align them and image all 3 fields. And then once we like all 3 fields, we will go back and treat them in reverse order. So, you may start at the head and then work down, and then, start superior and then go inferior, and then treat inferior back to superior once we like the entire setup. The other thing is that we keep the shift between isocenters very simple. So we have only a sup-im shift. We don't have any ant-post shifts, no right-left shifts between any of those isocenters. So it's a very simple shift that the therapists make, and they always make the same shift. And you basically split the difference. When you're doing all of your imaging going all the way down, you split the difference. And once you like that, then we keep those shifts the same. We don't change those based on image guidance. And the last thing is just considering like a slight gap between your matched fields to account for any uncertainty. So maybe something like a half cm gap. There's publications on craniospinal and how people do it that I would say the best thing to do would be to go look at those, published institutional examples of how they do the imaging, how they manage those uncertainties, and kind of develop kind of institutional protocol based on that.
Okay, we have another question from Aya. She's asking about the picture of the axillary field that you displayed before as an example of the IGRT protocols. And she asked that you said that the first imaging was by MV and the others are KV.
Okay, so I think probably where the confusion is here is what happens here is the first day includes port images. So it's, when I say MV, it's not just like an MV image, but it's really a port image to see what my treatment field looks like. And then probably at even day 1 would include the KV. So KV plus the ports on day 1, and then daily KV the following days.
Okay, well, this is the second time that you put the KV and the MV together, or portal image plus CBCT. I think you want to align to make sure by the portal image that the patient is anatomically in the same position from the simulation and avoid rotation by aligning the bony landmarks first, then having your KV CBCT, or there is another target to merge them together, particularly in the first treatment session.
Yeah, absolutely.
Yeah, so that's why, to avoid the rotation and aligning the bony landmarks tightly. Am I right?
Yeah, absolutely.
Okay. There is a question from Mayeda. She is asking what the meaning of different filters. Well, different filters means windows. Let's say اللي هي يعني ممكن اقول bony window اللي بتوريني البون اكتر، العظمه اكتر، soft tissue window اللي بتوريني soft tissue اكتر. الwindows filters like what we said, bony windows, soft tissue window, it's the same. So
yeah, so for instance, the Hounsfield units for this image, really they go from 0 to maybe 2000, right, or something like that. So this one, maybe basically the minimum that is being displayed is everything below, I don't know, 800 or something might be black, and everything above 1200 might be white. And then there's a gradient in between that. Whereas up here, it may be more like 1200 to 2000. as, from black to white or something like that. And here it's 0 to 2000. So basically, yeah, how you relate your intensity on the screen to your actual intensity of the image. That's what we mean by the windowing or the filters. I think for these ones here, actually, some of these may actually have a non-linear relationship, but you can do lots of fancy things. I think it's just important to know that there's options that are out there, and to make sure that however you do it, it's appropriate for what you're trying to match.
Okay, Rashid asked, is gapping an acceptable method to avoid overlap?
So we were talking about gapping for craniospinal cases. I think it really depends, and I think you need to, so for instance, if we do a gap, like a small gap for a craniospinal case, if we have multiple fractions, we'll probably change where that gap occurs. So move the fields, make one larger, one smaller, and change the gap location so that we don't get a cold spot every single time. It's something, I think there's a lot of ways to do it, and it's something to think about, what's the best for your practice, what are you the most comfortable with, and there's a lot of trade-offs there.
Well, I will share one of the papers that I shared from my center. It's very nice. It's a paper telling all about the supine position of craniospinal irradiation. And when we start, we didn't have a cone beam CT. We just have orthogonal portal images. And we used to have a gap, but with the feathering, what we call feathering, as we change the gap area every week in order not to have cold spots or hot spots, as you said. We do feathering technique all through the radiation course. Every week we had a different shift. So I will share this paper with the all groups. It's very useful and answering many questions for the craniospinal radiation.
Very good.
Well, I think we come to in case of couch rotation in non-coplanar beams. Does the DRR take an account for this during KV2D IGRT, or it will be confusing and we shouldn't depend on?
If you're using 3D matching, then it will definitely take it into account, right? Because you can just rotate, where is it? You could just rotate the CT because the CT is already a 3D set. So that can account for it pretty easily. For the 2D imaging, in my experience, it will account for it for your image. Like if you have these two images, it will account for it for this image because you can basically rotate this image to account for your couch rotation, but it will not rotate your lateral image, or it won't account for the rotation in your lateral image. So it might work for very small couch rotations. And honestly, if you have larger than that, then you probably have some other issues. It really should only be small rotations that you're worrying about.
Okay, Shaimat said, I didn't understand skin IGRT. What type of imaging do we take during setup, KV or MV? What's the meaning?
So I think surface imaging. It's optical.
Surface.
Actually. This is an optical image. So usually what happens is you can see here kind of this grid pattern. You have some sort of a grid that's aligned on the patient from one light source, and then that's detected by an optical. It's not KV, it's not MV, it's optical. Detects the locations on the surface and creates a 3D map of the surface. So it's not, it's optical. It's not KV, it's not MV.
In Electa, it's called catalyst. It's the catalyst. It's way of IGRT. I don't know, Shaimat, from Egypt or from Alexandria or not, but if you are, it's here in Egypt. It's in 2 hospitals. If you want me to share it with you, I can send you more information on the groups also. So I think we finished. We have just one single question from Zahra. This is the last one. She asked about the mask that is shown up when you have the slide about the surface imaging. she asked why the face is exposed. It's not covered. I think this is double layer mask. It's a double layer mask, so it's very thick, and it's for more sophisticated and more conformal techniques.
Yes, and the other
Like
thing is
EBRT or CYPER or something like that.
it's
It's a
specifically
cyborg.
for it's specifically for this surface imaging, right? So now you can see the skin itself as opposed to matching the mask.
Okay. And it's double layer, isn't it? It's thick.
I think so. Yeah, you have like you can see maybe here there's like a portion of it that's double layered, and a second layer that's a little bit larger.
So the aim here is to expose the skin where I'm going to have a surface imaging on.
Yes.
Okay. Great.
All right.
Thank you so much. Yeah, thank you so much. It was really, really enjoyable lecture. Thank you.
Very good. Take care, everybody.
Thank you so much. Thank you. Goodbye, everybody.
Goodbye. Thank you.